all people. Thank you. Over to you, Thiru.
Thank you, Dr. Rajkumar. Now I request our President, Dr. Rajendran sir, to start the program.
Yeah,
Next
thank you,
felicitations.
Dr. Thuru. Most respected our President, National President-elect Dr. Singavel sir, and President IAP TNSC 2024, and President-elect 2025 Dr. Somasundram, and Vice President Dr. Gopal Subramaniam, Secretary Dr. Narmada, Treasurer Dr. Rajkumar, and our President-elect 2026 Dr. Thirumurugan, and Academic Coordinator, and so our Vice President-elect 2026 Dr. M.S. Viswanathan, and all other dignitaries on behalf of IAP TNC, I welcome one and all. And so it's almost we are having 10th, 9th program of B2B under the leadership of Dr. Tangavelu sir. It's one of the most wanted program and most viewed program also our B2B. And it's actually back to basics. That's the concept. We have started targeting our basic the primary pediatrician. I think it is really useful to even postgraduate also. And I really thankful to our convener, Dr. Tangavelu sir. Today they are focusing on fluid therapy. On behalf of IAP TNC, welcome one and all. I think it's time to start the program. Thank you very much. Thank you.
Thank you, sir. Now I request our President-elect 2026 of IAP, Professor Singaravelu sir, to say a few words.
Thank you, Thiru. Most respected President Dr. Rajendran, Vice President Dr. Gopal, and Treasurer Dr. Rajkumar, and our scientific person who did extremely well. And yesterday I was in Kerala, the Presidential Action Plan, they projected B2B. So it was so popular. They, in their action plan, they are bringing back to basic. They gave the same name as B2B. Then I told this in Tamil Nadu, Thangavel sir, with our Presidential Action Plan at Rajendran, it is going very well. But anyway, whatever program we do, it is done at Kerala. We are very happy. Sir, in that way, I'm very thankful to Thangavel sir, spreading our scientific knowledge all over India to the pediatrician. And our President-elect 2026, Dr. Thiru, Vice President-elect Dr. MSV. And I really congratulate, because after the election, now only we are officially meeting, both of you, for getting elected. And this being the last program of this year of B2B, I'm sure that it will continue in future. I should be thankful to our President, Dr. Rajendran, for giving me the opportunity to work as a scientific convener for the entire, for all the program. Though I have not done much, all Thangavel sir for this program, each one. But this post gave me a very good visibility all over India, which helped me to achieve and to stand before you as a tall person in front of all of you. I should be ever thankful to Dr. Rajendra and his team for giving me a wonderful opportunity, and thankful to Thiru and Thangavel sir and Rajkumar, all who has done extremely well during this through science. We have been focused very well. Wherever I go during my campaigning, sir, your scientific program was so useful. The postgraduates, young pediatrician, even senior professors, all were telling. So, and they are regularly watching our YouTube. They are telling. Thanks to Thiru for tech savvy and producing all the academic activity into YouTube, which was very helpful. So the same thing definitely in future, when you are a president of Somasuram, all will do in the same way, so that Tamil Nadu will stand very high in front of all with great teachers like Thangavel sir and all. Without wasting much time, this present topic is very need of the hour, because in our days, we used to do what all sorts of peripheral venous access we do, cut down and everything. Thangavel sir might be knowing, all seniors might be. Now youngsters, they don't know what is cut down. That day has gone because a better technique has gone. But instead of that, patient exposure for young postgraduates and young pediatrician is getting less. Definitely this way of teaching will be definitely helpful to them to learn and when the case of crisis, when they sit in a periphery to help it. With this, I once again thank all of you for giving me this wonderful opportunity. Happy learning to all of you. Thank you, sir. Over to Thiru.
Thank you, sir. Now I request our Vice President of IAP Tamil Nadu, Dr. Gopal Subramaniam, to say a few words.
Gopal, unmute. A priest, I think he's a priest.
Looks like he's
Signal
not.
connected, sir.
Yeah, he's back. He's back. I think he's back.
Gopal,
Respected President, Rajiv sir.
video switch off பண்ணிடுங்க.
Yeah. Respected President Rajiv sir, National President-elect Singaravelu sir, respected Professor Tangavelu sir, Thiru, MSV, and all the dignitaries. It has been a great working atmosphere with Rajiv sir for a couple of years now. We have worked together for almost 4 or 5 years as he as a treasurer and he as secretary, and of course now as vice president to Rajendran sir. And our journey started in 1994 when I was junior resident in Jidmar along with him. And the journey continues. Thank you, sir, for giving me the opportunity to work with you as the vice president. And this has been a fantastic program. This particular Back to Basics has been a fantastic program by IIP TNSC, and wish the program a grand success, and let this program continue in the future with my friend Somasundaram and Thiru as future presidents of IIP Tamil Nadu. Let the program continue and wish the program a grand success. Thank you.
Thank you, sir. Now I request Pro Singaravelu sir, Tangavelu sir to take over the proceedings and start the program.
Thank you, Thiru. Thangavel sir, Singaravelu sir, always considered together. Many people, when they go outside, sir, your scientific program was so nice. So I got the value connection with Thangavel sir. That also helped me, sir. Thank you, sir. Thank you.
Thank you. My slides are visible. Am I audible?
Yes, sir. Yes, sir. Yeah, please, sir. So, Tangvel sir, you can
Thank
proceed. Yeah,
Thank you. At the
Yeah.
outset, I'd like to thank the organizers as well as IAP functionaries, starting from Professor Singaravelu sir, National President 2027, Dr. Rajendran, Professor Balashankar, Dr. Somasundaram, Dr. Gopal, Dr. Narmada, Dr. Rajkumar, Dr. Thirumurugan, and my dear MSV. Thank you all for giving us this opportunity. Today, we are going to discuss a very important topic. What the topic is? Today, we are discussing this topic in the background of Ditwa cyclone. Ditwa in Yemen language means a lagoon. Lagoon is a lake containing salt and water. That is a topic we are going to discuss in coalition with the Ditwa cyclone. Here we have this Tirkural, Neerindri Amayadu Ulagu. I just changed one word, Neerindri Amayadu Udal. Both Earth as well as human body cannot function in this world without water and salt. That is the importance of water and salt. We have 4 important young faculty who are going to talk to you about this topic, salt, water, and vascular access under 4 subheadings. Dr. Aisha, Dr. C. Harsha, Dr. Meenu, and then supported by a senior nurse, Sister Bhagya Lakshmi, working in Mehta Children's Hospital in the pediatric ward. 4 subheadings in which they are going to discuss is vascular access, IV fluids, various composition, IV fluid therapy in health, and disease. So some of the viewers wanted to have some few slides on electrolyte disturbances, correction the initial few hours before shifting the child to a tertiary care center. That's why we included. Once we say sodium and water, everybody will be perplexed and puzzled because this is a very confusing topic. But don't think like that. Salt is very close to us. If you see the South Indian coast of 1,000 kilometers across, lot of salt field, Uppalam, we have seen with heaps of sodium in the seashores. When you go to the kitchen, you see salt there. When you come to the dining table, you see the salt there. You go back to the history and see, we have fought a war against the British in the form of salt satyagraha. So salt is almost close to our heart. It is not away from us. Generally, philosophically, we can compare IV fluids and GARD. Both are present everywhere. If you go to PHC, there will be a IV fluid bottle will be there. When you go to tertiary care center, PICO also you will see there. This is a wide choice. Normal saline, ringer lactate, isolate P. Lot of wide choices there. Both are essential for survival. Of course, both are not very clearly understood by us. We have to treat them both with respect with regards to dose, volume, and time. The last 50 years, I did my house agency in 1974. A lot of things have happened, particularly with reference to vascular access in the last 50 years. As Professor Singaravil sir said, we started in 1974 with, before 1774, there is no vascular access devices, no scalp pain, no Venflon, no Piclane, no central venous catheters, no chemoport, no intravascular infusion. But what we had is only an IM needle broken into two pieces. In between, it will be connected by a catheter. And this is used as, imagine holding this needle tip with an artery forceps, inserting will have difficulty. Once you get a vein, before removing the artery forceps, it will get bulged. And then fixing is a very difficult, challenging job. From that, we moved on to the end of 1974. We had this wonderful device called butterfly set, where we were able to hold the wing without using the artery forces. Fixing was easier. From there, we had a lot of devices that come to us for help. One is Venflon in 1984. Later, central venous catheters with the advancement of pediatric intensive care units. Piclanes, peripherally inserted central venous catheters. And then Pulse brought in intravenous infusion emergency situation when IV is not available. And last is a blessing for all of us for treating chronic disease, including malignancy, is a chemoport. Now, commonly, chemoport is inserted for most children requiring long-term care. So, with this background, I invite the first faculty, Dr. Sriharsha, to talk about vascular access devices. She's a very brilliant student, had her MBBS from Coimbatore Medical College, DNB Pediatrics from Mehta Multispeciality Hospitals. She had second prize for poster presentation at 27th IAP National and Critical Care Conference, Pedicriticon 2025 on the topics restrictive fluid management in dengue shock. She received another prize for her presentation in Trendo 2024, case series of children with hypophosphatemia rickets. She authored a chapter in IJPP in the form of ASCII on rickets. She also contributed a chapter on rickets in the forthcoming book, IAP textbook of pediatric nephrology. She has also presented presentations in Chennai City Pediatric Forum and another situation, IAP National Critical Care Conference in 26 conference. With this, I invite Sriharsha to introduce the topic to the viewers. Over to Sriharsha.
Good evening, sir. I would like to thank Dr. Tangavelu sir and IAP TNSC for giving me this opportunity to present in this forum. I am going to discuss about the basics of the peripheral venous access and common topics. Yeah. Next slide, sir. So, what are the types of vascular access which can be achieved in the children? So, the vascular access commonly used in the hospital setup, in the emergency or the initial setup, is the peripheral access. So, the peripheral venous access can be in the umbilical venous catheter in the newborn period, or it can be a peripheral intravenous access, as shown by this red circle. It can be accessed in the lower limb veins, and it can be in the external jugular veins or in the scalp veins, which is rarely used nowadays. So when the peripheral venous access, other than the peripheral venous access, we can also get the central venous access, such as the peripherally inserted central catheters or non-tunnel central venous catheters, or the tunnel to central venous catheters, or the implantable ports. So the arterial, apart from the venous access, we get the arterial access in children, and for the purpose of whenever there is a difficult venous access, we go for the intraosseous access. The sites of intraosseous access include
Madam, you can switch off your
or the
video.
humerus. Next slide, sir.
You can switch off your video, then you can.
Okay, sir. Yeah. Yes, sir. Yes. It's my okay, sir. So the types of venous access in children, these are the central venous catheters which are available and which are usually commonly used. Whenever there is a need for infusions or medications or hospitalization in children beyond 2 weeks, we usually prefer the central venous catheters beyond 7 days of duration. So these are the non-tunnel central venous catheters which can be used up to 2 weeks safely. When there is a need beyond 2 weeks, we use the tunnel central venous catheter. Here in the right, this picture shows the tunnel central venous catheters. And the third picture shows the peripherally inserted central venous catheters or the PIC lines. The X-ray is here showing the peripherally inserted catheter and which is used as a central venous catheter. This can be used beyond more than 2 weeks. And in children for having malignancy or nowadays we can use the subcutaneously implanted port catheters. These are called as the subcutaneous. These are the subcutaneous ports in the last images. And we do have the needle, sterile needle called as the Huber's needle inserted into the subcutaneous port, and this is called as a chemo port, commonly used nowadays. So the peripheral, coming to the peripheral venous intravenous catheters or the access, the most common sites preferable in the children is the extremities. It can be either the upper extremities or the lower extremities. The scalp veins can also be used in the newborn period, but nowadays it is not commonly used. And the external jugular venous access is also rarely used. When there is a difficulty in peripheral venous access, we tend to go for the intraosseous infusion in case of critically ill children. So the indications for peripheral venous access in children include, this is the peripheral venous cannula or the Venflon which we commonly use, and it is a plastic tube which is inserted with the help of a needle and can be used to administer the fluids, medications and blood products. This peripheral intravenous cannula can be safely used up to 72 to 96 hours without being changed when there is no complications. So where it cannot be used, whenever there is an expected course of treatment beyond 7 days, or when there is a need, when there is a infusion of drugs or solution which has high risk of phlebitis, or solutions having high osmolarity such as dextrose concentrations beyond 12%, or when we use a total parenteral nutrition, this is not preferred. So the common color-coded IV cannulas which are used in the children pediatric population is the pink colored cannula 20 gauge, can be used beyond 12 years of age. It can deliver up to a fluid of almost 1 liter in 17 minutes. And beyond infancy period, we can use a blue cannula which is 22 gauge. It will deliver almost like 1 liter in 28 minutes. These cannulas can be safely used even in case of shock or hypotension for giving boluses. In infants and neonates, yellow cannula of 24 gauge can be used, which delivers almost 1 liter in 50 minutes. So this cannula can also be used for maintenance fluid of children up to 5 years. And in preterm children, a violet cannula of 26 gauge is used, and it gives around 1 liter in 77 minutes, approximately. We have to remember that lower the gauge, wider is the bore of the cannula. Wider the bore of the cannula, faster is going to be the flow of the flow rate. So apart from the Venflon, we have another device, the scalp vein set, otherwise called the butterfly set or the winged infusion set. This is called the butterfly set because it has, as just beside its cannula, there is a flexible butterfly wing, which gives a greater flexibility while insertion. And the parts of this butterfly set include a cannula, and we have a butterfly or a flexible wing, which is connected to a transparent tube, and we have a lure lock connector at the end. So the uses include it provides greater flexibility and better angulation while inserting, thereby easier access to the venous access, and it can be inserted even in thin and fragile veins. It is very less painful. However, the disadvantage using this butterfly set is it cannot be used for multi-purpose handling. And the common veins used in the pediatric population, in the pediatric population, we usually prefer the upper limb or the lower limbs. Extremities are preferred. In the upper limb, on the dorsum of the hand, we have the dorsal venous arch network, or we can also use the cephalic vein or the basilic vein. So on the ventral side, we have the cephalic vein going and the basilic vein, which can be used for the venous access. On the lower extremities, we use the dorsal venous arch on the dorsum of the foot, or we can go prefer the greater saphenous vein, which has a long course. The scalp veins, which are not commonly used, but however in the newborn period, can be accessed in the frontal vein or in the superficial temporal vein or in the posterior auricular vein, as shown here. The selection of the vein, how do we select a vein while accessing the peripheral vein? So it has to be a non-dominant upper extremity because it provides better comfort and it has a reduced risk of dislodgement of the Venflon and lower incident of thrombosis. However, in children who has thumb sucking habit, even if it is a non-dominant hand, preferably it has to be avoided. The vein, while selecting a vein, it has to be straight and preferably distalmost vein and non-branching veins, because the branching veins usually have venous valves, making it difficult for the access. On palpation of the vein should feel spongy and non-pulsatile, because hard veins suggestive of thrombosis, whereas pulsatile flow is suggestive of arterial vessel. How do we assess a difficult venous access before pricking the child? Any child who has a history of difficult venous access in the past, or on assessing the veins when there is a thrombosis or any other difficulty on selecting the vein, we can think that going to be a difficult or a failed successful attempt. However, there is a score called as the difficult intravenous access score, or the DIVA score, which has 3 predictors, that is visible vein, palpable vein, or age of the child. When a vein is visible, palpable, age of the child is beyond 36 months, the score is going to be 0 for each predictor. Whereas when a non-visible vein, non-palpable vein, and age of the child be less than 12 months, each predictor has a score of 2. Whenever there is a score of 4 or more, it is suggestive of more than 50% chance of having a failed first attempt of access. So what are the contraindications for any IV access? There is no absolute contraindication for any IV access. However, in children, there are few relative contraindications, such as when there is a severe coagulopathy in the child, or when there is a local infection at the site of access, or compromised skin due to burns at the site of insertion of the IV line. And in children who have had CKD and on dialysis with an AV fistula, the opposite hand is preferred. And in children who has a deep venous thrombosis on the same limb, the opposite limb is preferred. Whenever there is an expected extended course of intravenous therapy, so the other modes of IV access apart from the peripheral venous access are preferred to avoid the multiple cannulations. However, the clinical judgment to be used to balance the benefits and risk in such situations. How do we prepare for vascular access? First, confirm the patient identity, explain the procedure both to the parents and to the child, if at all beyond toddler, in their to their understanding. Have one helper to immobilize the child adequately, select an appropriate vein, avoid crossing the joints while choosing the vein. How do we increase the success of line placement? We can gently ballot or tap the skin overlying the vein and wipe the area with an antiseptic swab to increase the visibility of the vein. Apply a warm compress or soak the limb in warm water for a short period before line placement. Optimizing the ergonomics for the operator placing the line include patient positioning and ambient lighting. So what are the equipments needed for the intravenous access? So here, in this tray, we can see we have set up these are the things needed for the intravenous access. We need an antiseptic swab or sponge, preferably an 70% alcohol or 2% chlorhexidine solution, appropriate size intravenous cannulas, the tourniquets, sterile gloves and gauze, sterile normal saline flush, which is a pre-filled normal saline flush, and saline primed needle free connector or a needleless extension set, commonly used as the Q site. And if at all available, we can use a trans illumination device, sterile IV dressing like the Tegadam, and splinting and taping for the children. So this is the the role of local anesthesia before peripheral venous access. Is it necessary to local anesthetic in the peripheral venous access? Usually for local peripheral venous access is a small minimally invasive technique, so mostly it is not preferable. However, if at all we are applying a local anesthetic, the preferred one is a Prilox, which is containing a lidocaine and a prilocaine gel. The cream should be applied to the area where the needle will be inserted, and at least 30 to 60 minutes prior to the insertion. And it is not indicated in emergency situations. The complications can include, it can cause methemoglobinemia. So before inserting the IV line, we need to wipe the local anesthetic cream thoroughly just before inserting of the IV line. So the alternative methods to distract the child or reduce the distress of the child in infancy period we can use the oral sucrose solution or an EBM solution to calm the child while securing an IV line. So this is a extension set, needleless extension set, as shown in the third picture here. So this is a needle-free extension set which is connected to the Venflon, and it contains the following parts, like the connector to the Venflon site and the transparent tubing. It also has a clamp to clamp it, and it has an internal septum, split septum at the end. The first picture here. This is the lower lock axis, where it is the previous slide, sir. The end of it contains an internal split septum. This prevents, it has an automatic opening and closing system. So whenever we connect a syringe or an IV access, only then it opens. So, and when we disconnect, it gets closed. So how this prevents the entry of air and also reduces the risk of infection, and it also prevents the backflow of the blood. Yes, sir. So this is the trans-illumination device or a vein finder, which is nowadays available everywhere. And the uses of the illumination include, it is easy to use, and it has a better visibility. It provides a better visibility of the vein, and the vein will be the entire course of the vein can be easily seen, so that it increases the chances of successful cannulation even in the first attempt itself. So only the disadvantage of this vein finder includes it is costly and previous slides. So here in the image, yeah, it is costly, and it even has a poor penetration in the obese children. So this can be used even in dark to increase the visibility of the veins. Yes. Next video, please, sir. So this is the vein. This is here in this video, the vein finder or the trans-illumination device is being used. So this will increase the chance and the better visibility of the vein. The entire course or of the vein can be easily seen here. You can choose a non-branching vein.
சரி எடுத்துடலாம்
So these are the various types of trans-illumination devices available in the market, and the cost usually varies from around 2,500, and it can range up to 1 lakh to 2 lakhs. So whenever there is a difficult intravenous access, what do we prefer? When we can go for an alternative method called as the intraosseous access. In the peripheral setting, whenever we are securing an intraosseous access, we have to be careful. At least one person should be pulse trained before securing this. And the indications of the intraosseous access include any critically ill child where IV access cannot be obtained in 3 attempts or within 90 seconds. The indications include when the child has presence in shock, respiratory failure, comatose child, or when the child presents in cardiac arrest. So the contraindications for an intraosseous access include fracture of the bone, previous attempt in the same bone, when there is a skin infection at the site of insertion, or when there is an indwelling heart of the bone and any orthopedic surgery of tibia, lower end of tibia, lower end of femur. The types of intraosseous access includes a manual access or a machine-driven access. The complications are, it can lead on to growth plate injury when wrongly inserted. It can lead on to infection when not with sterile precautions, and it can also cause compartment syndrome. Here, the first image is showing the intraosseous needle, which is available commonly in everywhere. So this is the course of the intraosseous access, which is shown here. The Here the video, the procedure of
Pad
intraosseous
underneath an
access.
uninjured extremity at the knee to approximate 30 degrees of flexion. Identify the puncture site, which is the anteromedial surface of the proximal tibia, 1 to 3 centimeters below the tibial tubercle. Cleanse the puncture site and drape the area using local anesthesia if the patient is awake. Aiming away from the epiphyseal plate, introduce a short threaded or smooth large caliber bone aspiration needle with the bevel directed toward the foot. Using a gentle twisting or boring motion, advance the needle through the bone cortex into the marrow. Remove the stylet. Attach the needle to a syringe. Aspiration of bone marrow into the syringe confirms entry into the medullary cavity. Connect the needle to a large caliber IV tubing and begin fluid infusion. Apply antibiotic ointment, sterile dressing, and secure the needle and tubing in place. Pad underneath an uninjured extremity at the knee to approximate 30 degrees of flexion.
So here,
Identify the puncture
in this
site,
video,
which
we
is
have,
the
like as shown
anteromedial
here,
surface
first
of
we
the
have to
proximal
support
tibia,
the knee
1 to 3 centimeters
before
below
securing
the
the
tibial
IO
tubercle.
axis. We need to choose the site of access.
Cleanse the puncture
It
site
is
and
almost
drape
1
the
to 2
area
centimeter
using local
below
anesthesia
the
if the
tibial
patient is awake.
tuberosity, as shown here.
Aiming away from the epiphyseal plate, introduce a short threaded or smooth
It has to be done under sterile precautions.
bevel directed toward the foot.
And while inserting the needle, intraosseous needle, we have to be, it has to be inserted perpendicular, but slightly towards the ankle.
Remove the stylet.
To prevent the growth plate injury. So that is one method. And once inserted, it has to be, the insertion has to be in the screwing method.
Bone marrow
Once we feel some giveaway,
into the medullary
we
cavity.
need to aspirate and look for the blood flow, backflow of the blood. Once the backflow is confirmed,
and begin fluid.
We'll connect to the Q side, or we have to flush with the normal saline, and then we have to give the medications here.
And tubing in place.
Yes, sir. We can go for next slide, sir. So,
sir, you can just switch on your video,
yes,
so
sir.
you can have one photograph with your slides. I think you are going to answer the questions also.
Yes,
switch
sir.
on the video now. Okay. She has to leave earlier to catch a train. So questions are advanced to answer earlier. Okay, Arsha, these are the questions posted by Dr. Kausalya from Chennai, and then Dr. Raghuram from Dindigul. Okay, please answer the questions.
Yes, sir. So, how can we correct the dehydration in a peripheral center if an IV axis cannot be established? So, whenever the child is not comatose, like when the child is not in shock or when the child is not unconscious. So, when a child is conscious and but not able to take orally, we can preferably give the ORS through the NG tubes. So for a short period of time, and we can maintain dehydration status until an IV line is secured. But whenever the child presents in shock, or when, as shown earlier, or when the child is in shock, preferably IO access can be given. So, can we use a tourniquet in children while securing an IV line? Below which age it should not be used? So there is no age group, but we can use tourniquet in all children. Beyond infancy can be safely used, and while using the tourniquet, we have to be careful that tourniquet should not be very tight enough to occlude the arterial flow. The arterial pulsation should be felt, but it can be tight occlude the vein and increase the visibility of access. No, because when we use the arterial flow, so that is the thing regarding tourniquet. Beyond which age we can use? Preferably beyond 1 year of age, we can use tourniquet, because in infancy period, the holding technique itself will provide adequate in children and also immobilizes the hand in the infants. Is it ideal to draw blood from the vein flow axis for a blood test required or from another? So ideally, at the time of securing an IV access, we can draw the blood samples for blood tests. But later, it is less preferable. But we can sometimes, when there is a need, we can go for we can draw blood samples. But we have to be certain precautions needs to be taken when blood is drawn from the vein flow access later, after giving medications or IV fluids. Just half an hour before the before drawing the blood samples, we need to stop all the infusions and the medications. And just prior to the blood sampling, we have to at least let out, ensure adequate backflow, free backflow from the IV axis, and let out at least 1 ml of blood so that there is a clear backflow from the vein flow axis, and then we can draw blood samples from this site. So, and it usually gives a reliable values. So whether taping the secured IV line should be at the tip. So this taping the IV line, whenever you use a very tight plasters, it can sometimes occlude the flow at the when we tape it at the tip. So the tight plasters are usually less preferable to tape it completely around the arm. We can preferably use this micropores or the papered tapes, which do not usually occlude the flow. Venflon versus scalp vein, which is preferred and where it is used. Nowadays, the scalp veins are less preferred in the pediatric population because most of them are hospitalized for IV medications, like antibiotics or IV fluids, whatever it is. So Venflon is much preferred in the pediatric population. Scalp veins can be used when there is a one-time medication in the ER, like MSET or pantoprazole or anything in the when we give only a single-time medication. So because of its difficulty to maintain for a longer period. How to check the patency of the IV line, whether by pushing the medicine or normal saline? Usually to check the IV patency of the IV line, we have to check it with the pre-filled normal saline flushes. Normal saline is preferred to check the IV line patency because by pushing the medicine, it can lead on to extravasation. Usually, we don't push the medicine like antibiotics in pediatric population. It is usually given with an infusion of at least 30 ml of NS over a period of 20 to 30 minutes. So, one-time medication like MSIT only and pantoprazole only will be given by pushing the medicine, but preferably to check the patency, it is normal.
Thank you very much, Harsha. Very nicely projected and answer the questions also in a very clear manner. Thanks a lot. We'll move on to the next speaker, Sister Bhagya Lakshmi. She is an asset to any institution. She is in charge nurse working in pediatric ward, Chennai for the last 16 years. At faculty in vascular access CME for nurses and doctors in Thamirapattikkan and Tirunelveli. Many of the time, morning, she will take 10 minutes at least to teach young nurses about the common practical aspects. So she's going to tell the same knowledge. She's going to share with us practical aspect, which will be very useful even for a pediatrician or a community pediatrician or a nurse or even junior doctors. Over to Sister Bhagya.
Vanakkam to all. I am sincere thanks to Thangavelu sir for giving this great opportunity. So now I am going to present how to maintain a peripheral line while following strict aseptic precaution and preventing complication. So first of all, the before starting cannula, sir, move the slide, sir.
1 minute, sister. 1 minute, sister.
Yes.
Are you able to see the slide now?
No, sir.
It's moved. 1 minute, sir. Sorry for the problem. I'll stop sharing and then present again, sir. 1 minute.
Yes,
Please,
sir. Yes,
please.
sir.
Please stay. Are you able to see the slides now?
Slide வரலைங்க sir.
First, வந்துருச்சா?
sir, அது first அது என்னோட நேம்
Possible?
அந்த இது வந்திருக்குங்க.
Okay, sir. Okay. Can you just open your video for just few seconds so that you can have a photograph with your slide quickly? Fix your photograph with your slide. Okay, thank you. Thank you, sir. Okay, I will move the slide now.
Yes, sir.
Because all this faculty have taken a lot of pains. Almost last 2 weeks, I have been working on this for preparation and video. So I have to give the credit to them. Over to you, sister.
Yes, sir. Thank you, sir. So first of all, before starting the IV cannulation, you gather all necessary items. The size of cannula according to the children's age and visible vein and everything, and a tourniquet, antiseptic wipes, gauze and micropore, glove and plus solution. Whatever it is, easily getting saline or cath flash or Foshi plus anything, you prepare that. Select an appropriate vein, probably dorsal vein in the forearm or hand. Verify the patient before starting the cannula and identify and explain the procedure to the younger children, so the parents explain to the procedure, or adolescent or adult patient, you directly explain to the procedure into the patient. And mainly we are follow the technique. So what are all we are following? First of all, washing the hand, clean the insertion site with the antiseptic solution like chlorhexidine 70% or alcohol swab. Already the ready-made alcohol swab is available. And insert the catheter 15 to 30 degree angle. Secure the catheter with sterile dressing. So available in transparent decadum dressing, and monitor the IV site regularly. Why we are regularly monitoring the IV site? Na, if any complication or swelling, redness, na, before we can address that, and change IV tubing and dressing as per hospital policy. Transparent dressing preferred. Flush the peripheral line with a cap flush 10 units per ml or normal saline. Before and after medication and administration, and after blood sampling to maintain the patency with the flush. So next is
Moved, sir. There's some lag will be there. Now we can see.
Yes, sir. Regular inspection the IV line. Check for signs of complication like redness, swelling or tenderness, leakage, pain or warmth, and use a saline flush after each use to maintain patency. And sterile dressing should be changed every 48 to 72 hours are needed. And in case any redness or any complication or painful for the patient, typically every 70 to 96 hours to reduce the infection risk, can change the IV line immediately.
Change it. Slide change it.
Complication and management. Phlebitis, inflammation of the vein. The signs என்ன இருக்கும்னா redness, warmth, tenderness அந்த சைட்ல இருக்கும். மேனேஜ்மெண்ட் ரிமூவ் த இம்மிடியட்லி. இஃப் இந்த இதில் நம்ம எதுவுமே பார்த்தாலுமே redness, warmth or tenderness எது இருந்தாலுமே immediately you remove the IV line and apply cold compress or elevate the lymph. Lymph elevationக்கு can use pillow cover easily the hang பண்ணிக்கலாம். ஸோ அதனால அதை ஐஸ் பேக் அப்ளை பண்ணிக்கலாம். அண்ட் இப்போ ஆட்டோமேட்டிக்கலி இது ஒரு ப்ரிப்பேர்டாக வருது மேக்ஸெல்ஃப் magnesium sulfate ointment. Can use that, and thrombop ointment or ice pack apply பண்ணிக்கலாம். And the lymph elevation very important to immediately to reduce the swelling. So infiltration, extravasation when the IV fluid leakage into the surrounding tissue, and swelling, pallor and discomfort. Management, discontinue the IV access the site and use warm or cold compression. So most probably அதில் என்ன காஷனா பெனிடாயின் அண்ட் கால்சியம்லாம் ஐவி போகிறப்ப ஸோ we can more alertness to maintain the peripheral line. So infection complication and managementல வந்து bacterial fungal infection at the insertion site and redness, swelling, fever. So almost பேஷண்ட்டுக்கு ரெட்னஸ் அண்ட் ஸ்வெல்லிங் எது இருந்தாலுமே ஃபீவர் குறையாமல் இருந்தது வித்தவுட் எனி சிம்டம்ஸ் டயக்னோசிஸ்லன்னா இமீடியட்லாம் நம்ம ஃபோக்கஸ் பண்ண வேண்டியது ஐவி சைட்டு தான். பிகாஸ் ஐவி சைட்டில் எந்த ஸ்வெல்லிங் இருந்தாலுமே sometimes the patient having fever. So remove the catheter, clean the site and possible to start antibiotics. Blockage in the IV line, signs inability to flush the line. நம்ம flush கொடுக்கறப்ப சுத்தமா அது உள்ளவே போகாது. So very tight and cannulation. So the attempt to the clear the line with a saline flush or replace the IV line. Immediate திரும்பவுமே அதில் force பண்ணி push பண்ண வேண்டாம். So immediate we can remove the cannula. So after the insertion the cannula, கண்டிப்பா and include the date, time, site, catheter size and any complication இருந்தாலுமே நம்ம டாக்குமெண்ட் பண்ணிடணும். So monitor and record and keep track of any changes in the site, example redness, swelling and patient reactions. Report any complications like infiltration, phlebitis or infection should be reported promptly. No staff always staff எல்லா ஷிஃப்ட்லையுமே ஸ்டாஃப் வந்து இந்த விஷயத்தில் ப்ளபைட்டிஸ் வராமல் பார்த்துக்கணுன்னா ஸோ வி ஆர் மோர் கான்சியஸ். ஸோ எவ்ரி ஈச் ஷிஃப்ட் instruct the patient to inform staff if they feel pain, swelling or discomfort at the insertion site and teach patient to look for redness, swelling or unusual pain. And explain how the patient should avoid disturbing the catheter and the importance of notifying staff in there any issues. So regular monitoring, keep an eye on the line to each complication early, prevent infection through proper hand hygiene and sterile practice. And complication management வந்து understand how to manage common complications like phlebitis and infiltration.
தேங்க்யூ சார், ரொம்ப நைஸா எக்ஸ்பிளைன் பண்ணீங்க. தமிழும் இங்கிலீஷும் கலந்து ரொம்ப நல்லா இருந்தது. பிகாஸ் ஐ திங்க் நீங்க ப்ராக்டிகலா பண்றதுனால இட் வில் பி வெரி வெரி யூஸ்ஃபுல். கேன் யூ ஓபன் யுவர் video for a few seconds? I will take a photograph.
Thank you sir. Thank you sir.
She took a lot of pain to prepare the video also. The video வந்து self voice involved ஆயிருக்கும். இப்படி இல்லைன்னா she will also explain. Thank you so much, sir, because the practical was very, very useful for doctors, nurses, and everybody. We are much grateful to you. We will show the video prepared by her. She has taken some 3 or 4 videos and selected the best one. We'll show the video. Please tell me whether the video...
Yes, sir. Visible and audible, sir.
Somebody say whether this background sound is there and the video is working. Aksha?
Yes, sir. Audible and visible, sir. Background working, sir.
After choosing vein, performed hand hygiene using back to rub. alcohol-based rub and allowed to dry completely. Wear clean glove. Q site available single and double and triple lumen catheter. It can select according to the patient needs. Explain how to insert the cannula. So first he explained the procedure to the patient. Ensure good lighting and patient comfort. Position the arm and support it properly. Clean the skin using alcohol swab. Use a circular motion from inner to outer area. Allow the site to air dry. Cannula insertion. Anchor the vein with your non-dominant hand. Inspect at palpable to choose an appropriate vein. Prepare straight, visible vein. Most probably dorsal hand and the forearm. Avoid areas near joint and infection area or previous cannula. Apply tourniquet 70 to 10 centimeter above the Susan site. Ask the patient to make a first comfortable. Reassess the vein for size and direction. After insert the cannula, gently remove the needle and dispose of it safely. So can use flush the cannula with the normal saline like Poshi Plus or Heparin Flush or Cap Flush. Secure the cannula with transparent dressing or Easy Fix. To secure the Q site nicely, flush before giving the medicines to ensure patency. Administer the medication. Flush again after giving the medicines to clear the line. to document after securing the peripheral line, the staff name, date and time. Each shift nurses to visit the peripheral line and use the VIP score. VIP score is nothing. I showing you. It was visual infusion phlebitis scoring tool. In this tool, very useful to prevent the complication of phlebitis. Please ensure all the healthcare workers strictly follow the steps for peripheral line access using proper aseptic technique. This helps prevent complications such as phlebitis, infiltration and extravasation, and it ensures that we keep our patients safe.
Thank you very much, Sister Bhagya. We are really grateful to you for taking so much of time along with your another sister, Sister Sakti. She also helped her to make the video. Video has come up very well. Probably it will be very useful for everyone, including us. From this,
Thank you.
Yes, sister, please. Thank you so much. Thank you, sir.
Thank you, sir. Thank you. Thank you so much to
Thanks.
all to giving this opportunity, wonderful opportunity. Thanks, sir. Thank you, sir.
So from this, move on to the third faculty. Just an introduction. I'm just giving only the stories, superficial stories. Tough things like facts are given by our other colleagues. So I was working in a small hospital, a plantation hospital in 1976. It's called Velimal Estate. It is in the Kerala-Tamil Nadu border, about 70 kilometers interior to Theni Medical College. That is an interior forest area where we had a small hospital called 4-bedded hospital, was for the estate workers. There, what happened was, at one point of time, from that hospital, another 20-30 kilometers away, in the virgin forest, the workers working there consumed mushroom and developed vomiting and diarrhea. We received the news that about 25 to 30 people are lying down in the forest area, forest ground with dehydration. So it is unreachable area. So half the distance we covered by tractor and half by carrying. Of course, manpower is not, a lot of men were available. So we took some 10 to 15 people, each one of them carrying a bucket full of saline bottles, full of IV fluid bottles. We went there, we saw them pathetically, they were lying down in the forest ground. So it started IV fluids. Where is a stand? So only human being will act as a stand. You can see here, one person is holding 2 bottles for 2 patients. So we started, gave IV fluids, and maybe after 4 or 5 hours, most of them shifted from severe dehydration to mild dehydration, and then shifted back to the estate hospital. I given the list of all the IV fluids: normal saline, ringer lactate, GNS, isolate P, balanced electric solution. The joke of this story is, I was completely ignorant about various types of IV fluids, because immediately 1 year after my completion of MBBS, I didn't think I have a knowledge about all these IV fluid constituents, and probably my teacher would have taught us, but I didn't have that knowledge. Fortunately, I chosen normal saline and gave to these people. Other, if I given 5% dextrose or isolate P, probably all the 30 would have died. So that is importance of this knowledge of composition of IV fluids. This normal saline, one of the wonderful drug, because it is used even in a small peripheral center in PHEs as well as in ICUs, one of the very, very important drug. In the story of normal saline infusion, normal saline discovery is very interesting. In 1831, there is cholera epidemic was there in England. A lot of people died due to Indian cholera. About 28,000 victims had died due to Indian cholera. So at that time, in the team, there was a young MBBS doctor called William O. Sanasi. He was probably, at that time, was hardly in 25, like our 3 young faculty. He suggested his senior professor, said, sir, I read in one of the science journals that if we use salt solution, it will restore arterial properties and supply oxygen to blood, we can save them. So they prepared salt solution, 9% salt solution in a sterile environment, and then gave infused. So that is the end of the death. Thereafter, there was no death to cholera at all. So then it was followed by Thomas Latta. So both William O. Sanasi and Thomas Latta presented this as a paper in New England Journal, in New England Journal of Medicine, in, I think not maybe a different journal. In 1831, they published this as the first discovery of normal saline. It's the greatest discovery, and we should be thankful to the senior colleague who accepted the younger-most person's suggestions. So that's the beauty of it. I'll come to the last slide of my talk. Every living human is actually life started mainly in the ocean. I'm just including the stories because this is even though it is a fluid talk, it is a very dry talk, dry subject. So every life started first in the ocean, then to the clear water into the pond, then to the dry land, then to the desert. So every living human, every living being, when they left the ocean, they took a bag of sea around each cell, which later became the extracellular fluid. I'll repeat it. It's a fantastic story. Every living being, every cell, when they left the ocean, they carried a bag of sea around each cell, which later became the extracellular fluid. It's something like Sridhanam, what we give to our daughters. When they leave the parents' house, we give everything to them for their survival. Like that, they took the sea along with them. This is what the Claude Bernard, father of whom is described as internalization of the sea. So C is internalized into the cell, which is being explained as the extracellular fluid because ECF composition almost reflects the ocean. So that's the beauty of it. With this background, I invite Dr. Aisha Begum, our third faculty, to talk about various constitutions of intravenous fluid. She's also a very brilliant student. And she had an MBBS from Government Tiruvannamalai Medical College, DNP Pediatrics from Mehta Hospital. She's a runner-up in oral presentation in Marina Pedicon 2024. She also had an oral presentation in Sangam Pedicon 2023. She's a quiz winner in inter-college breastfeeding quiz in 2024. With this, I invite Dr. Aisha Begum, the faculty, to talk about IV fluid and their constituents. Over to Dr. Aisha.
Good evening to one and all present here. Myself, Dr. Aisha. Thanks to Thangavelu sir and IEP TNSC for giving me
Just
this.
open the video for a few slides so that I can have a photograph.
Okay, sir.
Keep talking. The same thing, keep talking to save time.
Okay, sir. The topic of my presentation will be body fluid compartments and which compartment is more important, and isotonic as well as the hypertonic fluid, and crystalloids and colloids, and about Holt-Seymour formula, and about some management of hyponatremia. Next slide, sir. Normally, we can make any home-based solution using easily available things like salt, sugar, water, and vinegar. Like this, also IV fluids also a major essential part in our life. Here, we are going to see about the IV fluids. This is the fluid compartments in our body. As we all know, the total body weight will be 60% will be the water, and remaining 40% will be the solid cell mass in our body. In that 60 in that 2/3 of the total body weight, it is divided into intracellular compartment and extracellular compartment. Intracellular compartment will be 2/3 and extracellular compartment will be 1/3 of total body weight. In the extracellular fluid also, we have two compartments, interstitial fluid as well as the intravascular fluid. Interstitial fluid will be 2/3 of ECF, and intravascular fluid will be the 1/3 of the ECF. We can compare this 2/3, 1/3 concept with the analogy of the world, where 2/3 of the world will be the sea and only 1/3 will be the land. Next. These are appropriate and inappropriate compartment for fluid. Normally, in the intravascular compartment will have the fluid which is like a liver or a lake. If the fluid gets filled in the third spacing or the interstitial fluid, it will be inappropriate. For example, if airport is full of fluid, means it is not a normal one. In interstitial fluid, if the fluid gets filled, it will be edema. In third spacing, it will be like ascites and the hydrothorax. We have to know about the concept of osmolarity and tonicity. Osmolarity is nothing but it is the total number of solutes in a solution, which is both permeable as well as non-permeable solutes, which contains of sodium, glucose, and urea. Tonicity means it is only the concentration of non-permeable solutes in the solution. That is only the sodium will determine the tonicity. Next. In tonicity, we have three parts: isotonic fluids, hypotonic, and hypertonic. As we all know, isotonic means the solution has the same concentration of solutes as the cell. So there is no net movement of water occur here. The cell volume remains stable. Example: normal cell and Ringer lactate. In case of hypertonic solution, the solution have the solutes concentration of the solutes will be lower compared to that of the cell, causing the water to move into the cell, and the cell will
Aisha,
get
can you switch on the video so that
cell will get
so that we become
swelled.
stable?
Example,
Can you switch
half
on the
normal
video?
saline, isolate P and isolate M or hypertonic solution.
Can you please switch on the video so that
Okay, sir.
there won't be fluctuations? Slides moved, I think, no? Can you see the slide?
Yes, sir. I can see the slide, sir.
Yeah, please explain. Okay.
Okay, sir. We are comparing this physiology of isotonic, hypertonic, and hypertonic solution with the food. Normally, if we put if we take the isotonic solution, the cell will be remains cell volume will be remains normal. For example, in case of if we put any rice to hypertonic solution, that is with a less salt, it will become a cooked rice. If in case of if we put anything in the hypertonic solution, that is with the excess of salt, like example, if we put a mango to the solution, it will get shrinked to become a pickle. These are the commonly used IV fluids, which is normal saline. Normal saline is an isotonic solution. DNS, which is sodium chloride with 5% of glucose. The solute, it will be isotonic, but it will be the osmolarity will be hyperosmolar because of the glucose content in it. And Hartmann solutions or Ringer lactate will be isotonic one only. These are free water in the isotonic hypertonic solution. In case of isotonic solutions like normal saline, oral, and the plasmolite, the concentration of glucose and the concentration of sodium and the water will be almost the same. There will be no free water. That is 154 millimole of sodium in 1 liter of water. There will be no free water in it. If we take half NS and isolate P, in case of half NS, the sodium will be 77. Which will be less compared to that of the water. So the free water will be 500 ml. In case of isolate P, the sodium will be very much less, which is only 25 milliosmol with the water, with the free water of 850 ml. Earlier days they have used an isolate P, which causes more hyponatremia. So they have stopped using the solution. These are some of the IV fluid bottles, 500 ml bottles of D10, D5, Ringer lactate and NS, and 100 ml bottles which we are normally using 25% dextrose and 3% NS. These are 10 ml bottles of sodium chloride solution, which is used commonly for the nebulization. This is crystalloids and colloids. Normally, fluid of choice will be crystalloids, which we are using our normal saline, other than a Ringer lactate. Plasmolite are less commonly used nowadays. Crystalloids are easily available, and it is economical, and it is the first fluid of choice in any resuscitation. And these are the colloids. Colloids are used in case of any fluid refractory shock. Most preferred one will be 5% albumin. Colloids are usually expensive and it will be less available. It has the side effects of allergy, coagulation dysfunctions, and renal complications. These are some of the IV fluid pockets, 500 ml pockets available. In this, especially, they have two ports. One will be IV fluid port, which is used for giving the IV fluids, and another one will be medication port, which is usually used for mixing the medications. IV fluid commonly we will use in clinical situations like fluid bolus for a shock, and fluid bolus for any deficit collection, and fluid for maintenance fluid, and for replacement under concurrent losses. In all situations, mostly we will use isotonic fluid, which is normal saline, as the fluid of choice. For replacement and concurrent loss, it can be variable. Next slide, sir. This is maintenance fluid requirement, which is a Holiday-Seeger formula. 4-2-1 rule. We can take in two pots. We can take in kg per hour as well as kg per day. In case of kg per hour, it is 4 ml per kg per hour for first 10 kg, and then for 10 to 20 kg, it is 2 ml per kg per hour plus 40. More than 20 kg, it will be 1 ml per kg per hour for every kg after 20 kg plus 60. In case of ml per kg per day, we can take 100 ml per kg per day for the first 10 kg and 50 ml per kg per day for second 10 kg, that is 10 to 20 kg plus the 1000. And more than 20 kg, we will take 20 ml per kg for every kg after 20 kg plus 1500. For example, if we take a for example, if we take 5 kg old child, by using ml per kg per hour, 8 into 4, which is 32 ml per hour, it will come. If we take by day 10 ml per 100 ml per kg per day, it is around 800 ml per day. Like that, we have to split the weights of 18 kg, 28 kg, and 68 kg. In 68 kg, the IV fluid calculation will come around 180 ml per hour, but the maximum IV fluid maintenance in case of pediatrics is 100 ml per hour only. Here we see some slides of management of hyponatremia. If the child is present with hyponatremia with seizure, which is symptomatic hyponatremia, first we will follow the Paul's protocol. First we have to stabilize the airway, which is positioning and suctioning, and breathing we have to maintain by means of bag and mask ventilation. And if any shock is there, we have to correct the shock. If any glucose instability is there, we have to correct it with the dextrose, and we have to control the temperature, and we have to control the seizures with the anti-seizure medications. Then we have to see whether the child is with dehydration or without signs of dehydration. With the signs of dehydration, first we have to give NS 20 ml per kg bolus over 1 to 2 hours. Without dehydration means we can give hypertonic saline, which is 3% NaCl, 5 ml per kg over 1 hour. It will use to maintain the correct the sodium levels. Then we have to transport the child to the PICU care with the pulse trained person. If the child is asymptomatic but the hyponatremia will be there, means first we have to check what is the fluid inflow. If it is isolate P or half DNS, which is any hypotonic solution, we have to change to normal saline, and we have to check the glucose levels. If the glucose level is high, it is most probably pseudo hyponatremia. Also, we have to check whether the sample is taken from the site that is proximal to the IV site, where the solution we are giving will be any hypotonic fluid we are giving. We have to change it to isotonic solution, that is normal saline, and we have to repeat the sample. And if we have to see whether the sample is lipidemic to ask the lab technician. This is also again a pseudo hyponatremia only. In case of asymptomatic hyponatremia, we can maintain with maintenance fluid of 150% with DNS along with the potassium. Thank you. Thank you for the opportunity, sir.
And thank you, Aisha. Very complicated calculations. You have very, very nicely explained. Few things just want to add to that. She mentioned about free water. She mentioned, I just want to reiterate again, free water means the water which is not bound to sodium. So in normal saline, there is no free water. In isolate B, 500 ml free water. In isolate B, 850 ml free water. In half normal saline, 500 ml free water. So what is the problem with free water? Free water causes osmotic shift across the cell membrane. So if the free water is excess, it causes hyponatremia and hyponatremic encephalopathy. That is the reason why isolate P is taken out of the pharmacy compartment, now replaced by normal saline as a maintenance fluid. Again, this 2/3, 1/3 also, Aisha explained it very nicely. I just want to rate it again. 2/3 of the world is made up of sea, only 1/3 is land. So our human body follows the Mother Earth. So 2/3 of the body is water. Total body water is 60%. Among this 2/3 is ICF, 1/3 is ECF. Again, 2/3, 1/3 in the ECF, 2/3 is interstitial fluid, 1/3 is intravascular fluid. Most important compartment is intravascular compartment. Aisha nicely told that water has to be in the river, not in the airport. That's what we saw during our last flood in Chennai. And this is, again, I just want to tell about holiday sugar. When everybody was in those days, the holiday sugar formula was introduced when I was born in those 1950s. So at the time, nobody knew what is the maintenance fluid for giving, for administration. So he's a pediatric nephrologist. He only designed this very, very simple rule. Anybody coming to join pediatrics, first day he will learn only this. 4-to-1 rule for hourly fluid, 150 and 20 for the daily fluid. One very challenging aspect is, at the age of 3, Malcolm Holiday was found to have single kidney. I don't know what made him to take up medicine and nephrology. Probably a single status propelled him to encourage him to take up medicine and later nephrology, and lived for about 85 years and contributed to a great to the medical society by offering this maintenance free recommend. Of course, last 5 years, this holiday second formula is being overruled and replaced by 2/3 of fluid maintenance. With this, I invite the next faculty, Dr. Meenu. Meenu is also very good postgraduate. She learned the life of balancing personal life with academic life. With his young son, he could finish DNB very nicely, passed recently. He had an MBBS from Government Medical College, Pariyaram, Kannur, DNB from Mehta Multi-Speciality Hospital, won second prize for oral paper presentation at the 22nd National Conference, IAP Growth, Development and Behavioral Pediatric Chapter in September 2023. He's also winner of Inter-College Quiz Competition on Neonatology 2024. Over to Dr. Meenu, who is going to talk on eye fluid health and disease status and also covering the rate of infusion. Aisha, Meenu, you can also just open your video for few slides so that we can have a photograph of you with the presentation. Meenu.
Good evening, sir. Good evening, one and all present here. I thank Dr. Thangavelu, sir, and members of IAP TNSE for giving me this opportunity. So my topic and contents are ensuring the rate of flow of IV fluid, dehydration, severity, IMNCI classification, Plan A, Plan B, Plan C, dengue, shock, hypoglycemia, then hypo and hyperkalemia. So next slide, sir. First, let us understand the difference between macro drip set and micro drip set. Macro drip set, as you can see, has a plastic nozzle. It has wider tubings. Therefore, the tube sizes, drop sizes are bigger diameter, that is 10 to 20 drops per ml. Hence, it is used for flask fluid infusion boluses. Whereas micro drip set, as you can see, has a needle-like tip. So the drops falling are also smaller diameter. It is 60 drops per ml. It is easy to titrate for children and infants. So the drop factor for micro drip set is 60 drops per ml, and for macro drip set, the drop factor is 20 drops per ml. As per Holiday Sega formula, for a 20 kg child, the maintenance IV fluid required is 60 ml per hour. So to deliver 60 ml per hour in a micro drip set, we have to set 60 drops per minute. Whereas in a macro drip set, it is 1/3, it is 20 drops per minute. Now let us understand the difference between infusion pump and syringe pumps. Infusion pump is ideal for larger fluid volumes over extended periods. It is better for general fluid delivery and is suitable for stationary use in hospitals or clinics, but it is higher costlier. Whereas syringe pumps can be used for smaller and precise dosage. Syringe pumps are more suitable for drugs like inodrops, insulin, dextrose, albumin. It is preferred for mobile settings or bedside care. It is cost effective compared to the infusion pump. Now moving on to dehydration correction, shock management in the initial hours. Now, degree of dehydration, as per the IMNCA, it is no dehydration, some dehydration, and severe dehydration. But in hospital practices, we usually say mild, moderate, and severe. As you can see in the graph, both mild and moderate dehydration comes under some dehydration. In mild dehydration, there are symptoms like fluid loss, thirst is there, and reduced urine output. Here, the treatment will be oral dehydration therapy. Whereas in moderate dehydration, there will be symptoms as well as signs of dehydration like dry mucosa, loss of skin turgor, and depressed anterior fontanelle. Here we can use oral dehydration therapy or IV fluid. In severe dehydration, that is patient presenting in shock, there are signs of dehydration as well as symptoms and features of shock present. So here we have to give treatment with IV fluid, rapid IV fluid, as well as 30-70 rule and 20-20-20 rule, which I'll be explaining in the further slides. Now, in the first image, you can see a child who is having severe dehydration. Child is unconscious, lethargic, there are no tears, and the oral mucosa is very much dry. Whereas a child with mild or moderate dehydration is conscious, is able to drink water. The next one important technique is to look for skin turgor. Here, as per the UNICEF, it is we have to pinch longitudinally to check for skin turgor. Now, degrees of dehydration. Based on degree of dehydration, there will be mild, moderate, and severe dehydration. For infant, it is 5%, less than 5% is mild, 5 to 10, and greater than 10 is severe. For child, 3%, 6%, and 9%. Type of dehydration based on another type of classification is hypotonic, isotonic, and hypertonic based on osmolarity. That's 270 is less than 270 is hypotonic. Isotonic will be 270 to 300, and hypertonic will be greater than 300. Based on sodium levels, sodium less than 130 is hypotonic, and isotonic will be 130 to 150, and hypertonic is greater than 150. Now, as per the IMNCA, as already told, there are 3 types of classification: no dehydration. In no dehydration, plan A is followed. In some dehydration, plan B is followed. And in severe dehydration with signs like child being lethargic, unconscious, and not able to drink, we follow plan C. All 3 will be explained in the further slides. Now, plan A. Plan A, we have to give oral dehydration solution or salted water like salted rice water, salted yogurt, drink, vegetable or chicken soup with salt can be given. For children who are less than 2 years, around half to quarter cup of fluid can be given. For 2 to 10 years child, we can give half to 1 large cup can be given for drinking. Whereas for older children, adults, they can drink as much as fluid as they want. Next is plan B. Plan B, ORS has to be given over 4 hours. If dehydration is persisting, then we can change to IV rehydration. In this figure, this table, we can see the amount of fluid that has to be given for the particular age and weight. You can take a screenshot or photograph. Now, for a 10 kg child with moderate dehydration, we have to give a dehydration correction as well as maintenance fluid. So that is 70 ml per kg, 700 ml plus 1000 ml for maintenance for 24 hours, total 1700 ml. This has to be given as 3 phases. Phase 1 is in the first hour, that is for restoration of intravascular volume. That is 20 ml per kg NS or RL over 1 hour. In phase 2, that is over the next 23 hours, the remaining fluid, that is 1500 ml has to be given. This is divided into 2 parts, 750 and 750 ml. And the first half is given in 8 hours and the second half is given in the remaining 16 hours. Next example is a child weighing 10 kg presenting to us with severe dehydration. Now we follow plan C, that is 30-70 rule. For infant, over the first 1 hour, 30 ml per kg, next 5 hours, 70 ml per kg. Beyond 1 year, we have to give this 30 ml per kg in first half an hour and next 70 ml per kg next 2.5 hours. If PICU facilities are available, then you have to correct the shock with 20 ml per kg NS or RL every 15 to 30 minutes. Another 20 ml per kg over 1 hour. Then continue 10 ml per kg until the shock is corrected. Once the shock is corrected, you have to give deficit correction and IV fluid maintenance. That is GNS plus KCl 1.5 times the maintenance. Now repeated boluses and repeated assessment, everything is essential. You have to check the electrolytes and be careful not to overload the patient with fluid. Even after all this treatment, if the patient is not improving, we have to keep other DDs in mind like septic shock, cardiogenic shock or hyperosmolar dehydration. Now dengue. Dengue, the child may present to us in compensated shock or hypotensive shock. In compensated shock, we have to give larger, smaller fluid over larger time. Whereas in hypotensive shock, we have to give larger amount of fluid over short time. So first bolus in compensated shock will be 10 ml per kg in 1 hour. Whereas in hypotensive shock, we have to give the bolus in 10 to 20 ml per kg over 15 to 30 minutes. We have to keep checking the hematocrit in between. If it is increasing or remaining high, we can consider a second bolus. However, if the hematocrit is falling and shock is persisting, we can give blood if there is overt bleeding. If there is no overt bleed, we can give colloid and reassess for further need for blood. We also have to keep myocardial impairment in mind. However, it is safe to restrict the fluid to 30 ml per kg initially. Otherwise, we can consider or refer to PIC facilities. Next is hypoglycemia cutoff and correction. It is a simplified form. As per the AIMS protocol, neonatology, blood glucose level less than 40 milligram per deciliter, plasma glucose level less than 45 is considered hypoglycemia for a neonate. And for infants and older children, 55 milligram per deciliter is considered. Based on Whipple's diet, that is plasma glucose less than 60 milligram and concurrent symptoms and resolution of symptoms on glucose correction. So cutoff for critical samples is plasma glucose less than 50 milligram per deciliter. So we have to keep 3 values in mind. For neonate, it is 45. For infants and older children, it is 50-55. Now moving on to treatment of acute hypoglycemia. If child is asymptomatic, that is the child can take orally. She is able to drink means we can give 15 gram of rapid acting carbohydrates, which may be in the form of 1 tablespoon of sugar, honey, or fruit juices can be given. If hypoglycemia does not improve even after second trial, then we can switch over to parenteral glucose. If child is very lethargic, symptomatic, not able to take orally, we can give IV 10% dextrose 2 to 4 ml per kg, followed by IV dextrose infusion. In infants, a GIR of 5 to 6 ml per kg per minute is followed, and for older children, 2 to 3 ml per kg per minute is followed. However, we have to monitor the glucose every 15 to 20 minutes until it is greater than 70 milligram per deciliter. Later, you can space out the monitoring. Now, initial management of hypokalemia. Here is a 10-month-old child who is admitted with 3 days of diarrhea. On examination, he was dehydrated and was found to have hypotonia, but reflexes were elicitable. Head lag was present. Heart rate was 124 beats per minute. It was a regular rhythm. On checking the lab values, electrolyte sodium was 140, potassium was 2.6, bicarb 17, urea 54, and creatinine was 0.5. And as you can see, the ECG was taken. It showed features of U waves were present, flat ST depression, flat and T waves were present. ECG changes were present. Now, management of hypokalemia. So most important thing is the airway breathing circulation. We have to check if there is any arrhythmia, any respiratory paralysis. We can divide into 2 categories: mild to moderate, that is greater than 2.5 milliequivalents. In that case, we can give oral correction, that is 2 to 3 milliequivalents per kg over 24 hours, or potassium-rich diet. We can give potassium and IV fluid maintenance, that is 40 milliequivalent per liter by adding 10 ml KCl with every 500 ml of IV fluid. If child is having severe or symptomatic hypokalemia, then better to admit in PICU and monitor the child under ECG monitoring. Cardiac monitoring is essential. We have to give correction of potassium, that is 1 milliequivalent per kg in 30 ml normal saline as IV per hour over 3 hours, that is 1 in 10 dilution in the PICU via a central line, always under cardiac monitoring. Throughout the procedure, we have to monitor for the airway breathing circulation. ECG leads has to be connected. We have to reassess the electrolytes always, and then we have to remember the general principles of potassium therapy. That is coming. The general principles of potassium therapy are: you have to use normal saline instead of dextrose. This helps in transcellular shift. After adding KCl in a solution, we have to mix well and ensure we label it correctly. And preparation has to be done by senior experienced person or staff. If more than 40 millimole per liter is given, it is very painful. It may cause severe blebitis. So we have to use larger peripheral line, or even central vein can be used. Always check for renal function and ECG. ECG is very much mandatory. We also have to check for magnesium levels, because replenishment of magnesium stores will facilitate easy and more rapid correction. And also mix KCl only in full infusion bottle, never in half or half-filled bottles. The in market pot chlor available is 50 ml. 15 ml is equal to 20 millimole, and 1 ml of IV KCl is equal to 2 millimole. Next is hyperkalemia, that is potassium level more than 5.5 or 6 milliequivalent per liter. First, we have to exclude spurious hyperkalemia. We also have to check for symptoms, any other causes, any ECG changes present, what are the risk factors. If the child is in renal failure, you have to check for urea, creatinine, and other electrolytes. If child is having serum potassium between 5.5 to 6 and child is not in renal failure, we can stop all external sources of potassium, and we can give salbutamol nebulization. But however, if child's potassium is greater than 6, we have to give further medical management. In this ECG, you can see changes like tall T waves can be seen. Now, management of hyperkalemia. IV calcium gluconate we can give 0.5 to 1 ml per kg in 5% dextrose. This is always given as slow IV over 20 minutes, and we have to be careful regarding the heart rate and ECG. ECG has to be monitored. Next is IV sodium bicarbonate, 8.4%, 1 to 2 milliequivalent per kg IV over 20 minutes, diluted with equal volume of 5% dextrose. Caution here is flush the line with NS in between the infusion. Next is insulin and dextrose. Add 5 units of short-acting insulin, that is attrapid, to 100 ml of 25% dextrose, that is 2 ml per kg, given as slow IV over 1 hour. This will give 0.1 units of insulin over 500 milligram of dextrose is given. So while using this, we have to check the CBG every 15 minutes. Next method is nebulization with salbutamol and sodium potassium exchange resins. If all these methods are not working, we can consider dialysis. This is an important slide. A screenshot or photograph can be taken. With this, my topic is ending. Thank you everyone for giving me this opportunity.
Thank you very much, Meenu. It's very, very clear. I don't know, in my age, your age group, how I was, I can't think of it. You have all three have a good teaching ability with clear delivery of facts. So to just conclude, few more slides. Signs of dehydration, I just want to reiterate the points what Meenu told earlier. Only symptoms, no signs. That is mild. What are the symptoms? History of fluid loss, like diarrhea, increased thirst, reduced urine frequency. When you take the water and take too close to a child will be avidly drinking the water. That is symptoms. Signs means depressed antifondal, dry tongue, loss of skin turgor. Symptoms and signs are there, it's moderate dehydration. Symptoms, signs are there, plus signs of shock, which are tachycardia, weak pulses, prolonged CRT, hypotension. Then it is severe dehydration. It's a simple way of classifying by the practical side. Monitoring therapy is just table taken from Nelson, very simple one. Monitor the vital sign. Any child who's got IV fluids, so I check the vital signs, at least 6th valley or 8th valley, pulse, blood pressure, intake and output chart, fluid balance, urine output, physical examination. Every day we have to weigh the child to see whether the child has lost weight, signs of dehydration, gained weight, signs of volume overload. Look for clinical signs of depletion or overload. And we are supposed to check the electrolyte if the child is receiving IV fluid for 48 hours. To conclude, knowledge about vascular access and IV fluid therapy are essential for practice at all levels. Always prefer isotonic fluids than hypertonic fluid. Nowadays, things have changed. I was using isolate P for a long time. Now, last few years, isolate P has been removed. Only fluid beyond 28 days of life. Only maintenance fluid is GNS or normal saline, or balanced electrolyte solution or inner lactate. Never off normal saline or isolate P. The newer developments like QSAID, which the first speaker explained about the QSAID, is very useful one. It's costing around 350 rupees, but quite useful. The single extension tube, there is no backflow at all, no need to use the needle. Just fit the syringe, give the drug. When you take it out, there is no backflow. Vein finder, there are different costs available, different costs. It's worth having a vein finder as well as the Cook intraosseous needle, which is a round one. It is costing around, I think, 2,500 or 2,000 rupees. It's very good thing for any hospital because the child comes in shock or unable to get an IV line, child will die. So this Cook needle will be very helpful. Worth having this in our emergency room, and even in a small hospital, it will be worthwhile to have it. The child has a sodium of 120. Dr. Raghuraman and Dr. Kausalya wanted this. I think it's a useful one. Before shifting the child with hyponatremia to a nearby center, at least start correcting them. So initial few hours, you can do the management as mentioned by the speakers. Before shifting a child with hyponatremia and hypokalemia, stabilize the ABC of the child and start the initial management. With that, you can shift the child to the nearest PICU. Basics of IV fluid therapy should be taught to all nurses and doctors periodically. It is a useful way of improving our knowledge, which is going to be a practically useful one for the patients. Thank you very much for a patient listening and for giving us opportunity. We have only provided the basic aspects of fluid therapy. If you want to have a detailed, in-depth facts about vascular access and fluid therapy, you have to attend the workshop earlier organized by Dr. Aruna Rajendran and Dr. Sasidharan in different places, Tamarapadika and MMC and many places, 5 or 6 workshops are conducted. It runs for 2 days. They also teach little more advanced aspects. Suppose a child has been shifted from PICU to a smaller hospital with a PIC line, how to handle the PIC line, how to handle the chemo port, all that are being taught. If you happen to see this workshop, please attend. You will have a 2 days workshop. It will teach you all the aspects of vascular access and fluid therapy. Before closing, I just stop sharing. I want all the faculty to be coming on the screen with keeping their video open so that you can have a photograph with the IAP functionaries and senior teachers. I'm not very sure to bring all them in one thing. Any one of you can bring it. We can. Sir, Rajendra sir, Thiru, Singaravel sir, Sivaprasad sir, all of you can open your videos. Our faculty can have photograph with you all. Aisha, Bhagyalakshmi, Meenu, Harsha. Some of you can take this. If I fail, at least a few of you can catch all the faculty in one monitor with all the senior teachers. I will try to take. Rajendran sir, Shivaprakasham sir is there. Thiru is there. Thank you very much. Thanks all the faculty. And some more questions I will answer. I'll just read out the questions and then answer. One question is whether we have to add potassium for every time when you give maintenance fluid. That was the question asked. Yes, if possible, potassium should be present in the IV maintenance fluid, but there is a risk of mixing it. Whenever we write potassium, no, always we are worried about how it is being mixed. It should be done only by a senior nurse or as a doctor. And 5 ml of KCl mixed with 500 ml of IV fluid is a maintenance fluid that has to be properly mixed. But we can't expect everything at the same time. So that is a problem in it. So in that situation, if the child is not having diarrhea or vomiting or not having nebulizations, probably you can administer for the first 24 to 48 hours. You can administer without potassium. But if you have to add potassium, better leave it to a senior nurse. Leave it to a senior nurse so that they can mix it properly and bring it in the properly label it so that it is not injudiciously misused. So potassium is a very, very dangerous drug. It has to be handled very safely. And then another question is, one is there any indication for isolate B or hypertonic solutions? So isotonic solutions are the one used for all maintenance fluid, but hypertonic fluids can be used for hypernatremia. Those situations only you can use. Otherwise, only GNS can be used, only normal saline, GNS or ringer lactate or balanced electrolyte solution called plasma light. Only these things can be used. And a few more questions, I'll just see. Any questions? Probably we can any question chat box. Through or any one of your faculty can just find out any questions in the chat box.
There is one question, sir. If child can't be able to take
Child cannot take
orally, can we give through NG tube? Oral
definitely.
ORS, can we give it through NG?
Definitely, that was done earlier also. So if the child is dehydrated, you can't get an IV lane, you are in the remote periphery, you can try oral, or if not, pass an NGT and give ORS. It's not at all going to be causing any problem. It will save the children. So it was done earlier also. And then another question is, should 5% dextrose to be routinely added in the maintenance fluid? Like, why can't we give only normal saline? Why GNS? The GNS, the dextrose, will it cause hypertonicity? No. All children will be in the fasting stage, may need dextrose. So in the maintenance fluid should be only 5% dextrose normal saline or GNS, popularly called, instead of normal saline. Otherwise, they will be develop hypoglycemia. And then can we use temporarily stop the IV bottles, IV fluid flow for a few hours in the day or in the night? Is it correct or not? Yes, definitely we can stop. The child is not sleeping, can stop for a few hours. At that time, we can flush the line with normal saline before and after, so that it may remain patent the next day also. Should we adjust the IV fluid along the oral fluid intake? Yes. Particularly children with bronchiolitis or respiratory distress, they are prone to have SIDH. The fluid has to be meticulously balanced. If the child is taking good oral fluids, we can stop the IV fluids. If the child is taking only 50% of the oral fluid, combined oral fluids and IV fluids should be taken into account to see the correct volume administered. Nowadays, we don't give full maintenance. Holiday sugar is still staying there, but holiday sugar formula is used and calculated and give only 2/3 maintenance for all children admitted. That is a new thing. It's not a new thing. Last few years, we have been followed in ICU. In general ward also, we are following it. Why? Because whenever there is a child is hospitalized, or then the child has an acute illness like respiratory distress or vomiting, they have like SADH. So ADH will retain more water, causing hyponatremia encephalopathy. That was responsible for hospital-associated hyponatremia and death. So all children should receive only 2/3 maintenance. I will repeat it. A 10 kg child, as per the holiday sugar formula, may need 40 ml per hour. Instead of 40 ml per hour, we have to give 28 ml per hour of 5% GNS with appropriate potassium. Okay, practical points to alert fluid overload or wrong eye fluids are simple ways of monitoring. Simple ways of monitoring, I already told, the pulse, the respiration, weighing the child, every day weighing the child while identifying the fluid overload. The child receiving eye fluid, child will be respiratory distress and requiring oxygen mean that is an evidence of fluid overload, particularly we see in dengue. If the child receiving maintenance fluid also develops a tachypnea and requiring oxygen means first suspicion is fluid overload causing hypoxia requiring oxygen. So we have to reduce the fluid or stop the fluids. Which eye fluid should never be used in children? That is isolate P. Once upon a time, isolate P was a hero for us. Now it has become a villain. How to calculate the fluids in overweight children? A boy weighing with 15 years, 95 kg weight. You can't give that much of fluid. So you have to calculate the ideal body weight. What is the ideal body weight? Take the 50% when you take the weight chart, 50% centile, take it as an ideal body weight. So you can't use the actual weight. It's only the ideal body weight should be used for calculating fluids. As Dr. Aish already mentioned, 60 kg child may require 108 ml per hour, but we can't use it. So maximum fluid for adult or children or adult or adolescent children are 100 ml per hour. Any condition where isolated P can be used in children? No, but it can be used in hypernatremia during management of hypernatremia. So these are all the questions. Any more questions in the chat box? I can answer. Any?
There are a few questions, sir.
Please.
What is the maintenance fluid in a newborn on third day?
Newborn is a VIP. Newborn is a VIP that has to be handled only by VIPs, neonatologists. So we can't comment about it. All the fluid calculation formulations are about 28 days of life. Neonate, it is a separate category. A VIP, we can't comment about it. Only a neonatologist will decide about it.
Use of half normal saline, sir.
Half normal saline is also again only for management of hypernatremia. If you take about 2-3 earlier editions of Nelson, they used to tell less than 20 kg maintenance fluid is half normal saline, more than 20 kg GNS. But now, completely clearly, current Nelson says that beyond 28 days of life, maintenance fluid is only glucose, 5% glucose normal saline. So half normal saline can be used in two situations. One is management of hypernatremia, where we have to give hypertonic fluid 1.5 time maintenance. There you can use it. Second situation is in the management of diabetic ketoacidosis. When the sodium is rising 140, 145, 150, instead of giving GNS, we can give half GNS. That can be used.
Another indication for bicarbonate correction in diarrhea.
Diarrhea, that mistake we have done when we are all younger. But nowadays, bicarb therapy is not at all used. Bicarb therapy is a little more dangerous drug. For the reason is bicarbonate osmolality is 2000 plus. So more than normal saline, 7 times that of normal saline. So high osmolar solution should not be used. Second one is bicarbonate therapy will cause hypernatremia. Bicarbonate therapy will correct the acidosis. Paradoxically, it increases acidosis intracellularly, intracranially. And fourth is it can cause hypokalemia. It can cause hypernatremia. So because of these reasons, sodium bicarbonate is never used in diarrheal dehydration. It is used only in selective situations. For example, one is selective situation. One is in septic shock, acidosis still persists. When the inotropes are not working, you can use bicarbonate after correction of the crystalloid and colloid boluses. And only one situation we never used in diarrhea dehydration. Then how it is corrected? Because kidney is the all-rounder healer. Kidney and liver are the all-round healer. So kidney generates bicarbonate. So it corrects the deficit. Once you correct the shock, once you correct the dehydration, kidney generates bicarbonate. Again, one strong contraindication bicarbonate therapy is diabetic ketoacidosis. Then how the bicarbonate is produced? So kidney converts all keto acid into bicarbonates. Kidney and liver are safeguarders. Only situation where without asking any question, without doing any blood gas, we will give bicarbonate is any young PG can post in the chat box. Only situation where you can unmute and answer. We don't ask any question. We don't ask ABG, but we'll give bicarbonate. Hello? Yes, cyanotic spells. Very good. Cyanotic spells. Cyanotic spells, the only situation we never think anything. Immediately we give bicarbonate because the acidosis will worsen the shunting and worsen the cyanosis. Okay, any more questions?
What will be the plan of management in an encephalitis child with acute kidney injury with hypernatremia?
Very tough question.
Yes.
Anyhow, I'll add one by one. For
Yes,
any
sir.
CNS infection, ideal fluid is normal saline. It's not GNS. Ideally, we use isotonic fluid. Why we should not give dextrose? Because in the presence of ICP due to intracranial condition like intracranial bleed or CNS infection, there will be stress hyperglycemia will be more. Stress hyperglycemia is dangerous to brain. So in that situation, the ideal fluid is normal saline at 2/3 or 50% maintenance, and periodically we have to check the glucose. If there is hypoglycemia, we can add glucose. If there is hyperglycemia, we have to manage it. And when encephalitis and acute kidney injury is both combined, means fluid management is very, very difficult. So it has to be admitted in ICU. Hourly, child has to follow the fluid balance, check the electrolytes, check the renal status, check the kidneys excreting. So all depending on that only we can take a decision. What is the third culprit? One is CNS infection. Second is AK. What is the third villain?
Hypernatremia, sir.
Hypernatremia. So in those situations, hypernatremia has got multiple electrolyte disturbances or hypernatremia associated with acute kidney injury. Only way to manage that is not the fluid calculation, only by dialysis or CRRT. Only kidney can help. I told you, kidney and liver are the saviors. Only kidney can help. So CRRT or dialysis.
Last question is indications for colloid by Dr.
So, we thoroughly enjoyed because this fluid electrolyte is a very, very interesting subject. When you understand, it's like mathematics. So indication of colloids were initially used in septic shock, now also being used, but more predominantly colloids are used in dengue shock. In low resource settings, we are all working in public sector hospitals. We used to have synthetic colloids, Hetastarch, Hemacell, these are all used. Now, the colloids to some, even though studies does not say that colloids are beneficial than crystalloids, but practically speaking, colloid stays in the intravascular compartment longer than the crystalloids. So that way it is helpful. Nowadays, synthetic colloids are not used. We use only IV albumin, even though it is expensive. IV albumin at the natural colloid is used for correction of shock in dengue. Some situation it's also used in septic shock. So synthetic colloids are not used because of their lot of side effects, which I think Aisha mentioned. I think it causes coagulation disturbances, and it can also cause acute kidney injury. So because of allergic reactions, because of this, synthetic colloids are not used. Only IV albumin is used, preferably in dengue, non-responding to crystalloids, sometimes in septic shock.
End of question, sir.
Thank you very much. Thanks a lot all for your patient listening. And thanks once again, IAPTNSC, Dr. Rajendran, Dr. Thiru, and Dr. Narmada, and everybody, Dr. Gopal, everybody for giving us an opportunity to read this subject again. And I'm thankful to my young faculty. I'm very, very sure. And at the age of your age, around 30s, what I was doing is, I can't tell you. Because we didn't have this much of knowledge or this much of teaching ability to talk in front of seniors and larger audience. Thank you very much, my young faculty, and Sister Bhagyalakshmi, specifically, special thanks to you, sister.
Thank you, sir. Thank you so much, sir.
Super, sir. Super.
Thank you, sir. Thank you so much, sir.
Thank you for the opportunity.
Thank you very much, sir, for a very exhilarating session. I think the whole session was very well planned out, and everybody was very benefited from the session. I think we have still got one more to go next December for the last one before we sign off for this year. Thank you very much, sir. Good night, sir.